often has two canals. But how often, though? I was thinking, and I found this amazing study that was made by Dr. Mohammed Mukhtar Negi, who's also my supervisor at Ain Shams when I was doing my thesis. And he generated a study about the Egyptian population and the presence of the MB2. I'm sorry. So he realized that the presence of the MB2 in the upper six is 74.5%, and in the upper seven, it's 57.8%. He also concluded that the Vertucci type 2 of the types of the canals is present at most percentage, followed by type 1 and type 3. So what are the types? Well, the type 1 is two canals merging coronally into one canal and one apex. Type 2 is two canals merging apically, and type 3 is separate. But are they separate? Well, no, because Dr. Hess, in the past, a century ago, almost included, and for sure, there is an isthmus and anastomosis connections between the two canals. So we might say, if I clean the MB1 really good, I can leave the MB2, right? But the researchers have a different idea, that if the MB1 has bacteria, then the MB2 must surely has bacteria. And even worse if we leave it, because it will be unnegotiated. So what is the prevalence of failure? Can the tooth fail just because of the MB2? Yes, it can. And the failures arise from 46% to 78% sometimes. This is the type of X-ray we see sometimes, a perfectly obturated MB1, and bam, and radiolucency above the mesiobuccal root. Like this case, I was lucky to see without a CBCT that the radiolucency is profuse around the mesiobuccal root, and luckily it had a missed MB2 that was detected and obturated. So is the prevalence of localization easy? Am I gonna find it? Well, actually it depends, and it depends upon the magnification. Notice in the chart, 50% is undetected without magnification, but 40% is almost detected with magnification. So never underestimate the power of seeing. Is the tooth vital or necrotic? Will this make a difference? Sometimes clinically, you will see a vital tooth that has a missed MB2. The patient will come with a vague pain. He will be in pain from hot sometimes, from cold sometimes. Necrotic teeth almost mostly have apical pathology in the form of abscess. But the golden standards between vital and necrotic is actually visual inspection. Sometimes we do pulp testing. I was just speaking with Dr. Hassan about the tricks he taught me when I was much younger. But pulp testing can actually sometimes be misleading if the tooth is vital and sometimes have something called partial necrosis, which is most of the time. And also there's a lot of rules for pulp testing. If the tooth is crowned, if the tooth has an amalgam, it might not give you a very accurate reading. So pulp testing is an option. Also, cold test is an option, which prevails to 90%, and Hoy test as well. And also the CBCT, which is present at EgyptAir Hospital in very high quality. Or I might not need it in this case, which is so straightforward, just 4 canals, and I didn't need a CBCT for it. So how do we detect the MB2? As we said, magnification. For the younger generations, the studies most tell you that we need the loops of a minimum of 3.5x, and also a dental microscope. With direct vision, the prevalence is 53% of you finding the MB2, but with the microscope, it increases to 90. So with no magnification, expect your finding of the MB2 to decrease to 17%. Yes, we have to see. So where is this MB2? Well, it is mesial of the mesiobuccal 1, 2 millimeter. And if you draw a line from the MB1 to the palatal canal, you're most likely to see it in the subpulpal groove 3 to 0.5 millimeter. But beware, we do not trough on the furcation area. The red line is the no. So always troughing on the mesial aspect in a palatal direction. How can we go from this photo to this photo? We always see this photo, a hazardous dentin map, and then when we trough and clean, we see more orifices. So it all starts with the access. Yes, your visibility form and drawing a perfect outline that makes the internal anatomy evolve to the external, not me forcing an external into the internal. Also, your convenience form, your access of the file unobstructed inside the canals, and straight line access. So, visibility, convenience, and straight line access. I love this case because it's one of my favorite cases. An upper 7 with 4 roots, and the Mizubaka root had a type 4, which is one canal merging into 2 apical exits. Or this case that was really done in EgyptAir Hospital, you can never negotiate that elbow curve without a straight line access. So never underestimate your access. Also, there is a study that entails that loss of structural integrity will most probably reduce your flexural strength. Yes, your access is what weakens the tooth. Not, okay, most probably your irrigation and clingo shaping can contribute. But if you preserve your dentin, if you preserve your pericervical dentin, if you draw an access that's not overextended, you're most likely to ensure a longer outcome of your tooth. Oh, sorry. These 2 cases were actually 4 canals, as you can see, with the MB2 detected and obturated. But these cases are both over 50, and they both came with the vague pain. So yes, age sometimes may be a contributing factor, but they were over 50 and they still had the MB2. So we must look for it under all conditions. So what is the perfect axis? Well, I'm drawing the axis, the base of the axis is mesial, and the peak of my triangle is palatal. In cases of the upper 6, I'm gonna do a rhomboidal shape, extending my axis besides the MB1 to make room for troughing. Be careful of the mouse hole effect. A lot of the younger generations come and tell us, doctor, the orifice is so small, it's probably calcified. No, it's maybe your axis is underextended. I'm gonna show a video right now of an upper 6 that sadly didn't have the MB2, but to show you what an axis would be like. So we have the round burr, just dentin dropping, the SF41, which is present in EgyptAir Hospital, drawing the outline, as you can see, without overextending inside the pulp chamber, endozebra, safe cutting end. What's this? A small pulp stone. Yes, pulp stones can be small. They don't have to be huge as we all thought. Troughing ultrasonics away from the furcation into the palatal aspect. I'm using here the the E3D from woodpecker, which is diamond cutting. Irrigation, concentrated sodium hypochlorite to flush away the debris, and voila. Sodium hypochlorite in action, beautiful bubbles digesting away the organic tissue. I'm always working in a wet medium with sodium hypochlorite, and here I'm using my first rotary file. Cleaning, amazing, it looks amazing. So the steps for troughing, as I said, the E3D from woodpecker, I love it. Also the E3, which is not cutting, for minimal troughing or maybe just smoothing out more because it's not end cutting. And your best friend, your endodontic explorer, the DG16, okay? Along with the ultrasonic woodpecker that's present also in EgyptAir. I'm always working in a wet medium of concentrated irrigation. Studies do suggest heating your irrigation. How can we do that? Well, you need your heated plugger of the obturation. Sometimes people insert it inside the irrigant when it's retained inside the pulp chamber, and you can adjust the temperature and then you can heat the irrigation. These tips are from 18th medical. That's when I activate the irrigant. Yes, you must activate the irrigant to disengage the smear layer. So a lot of the younger generation come and say, doctor, is it the canal or the perforation? Well, the canal will do something called the tuning fork. As you can see, it's the springing action. The file is in total engagement. It springs back to you. In the cases of perforation, it won't do that. You will feel the stabbing of the periodontium. You will also feel profuse bleeding that's uncontrolled, really, how much you irrigate. And Dr. Amr was so kind one time to refer the reading of the apex locator, because yes, almost always the reading of the apex locator in cases of perforation will hit 0 once you put in the file. So what is the protocol? Should the first file to touch the orifices be the orifice opener or the manual file? What do you think? Okay, who says the manual file? Okay, who says the orifice opener? Okay. Well, according to studies, when you clean and shape and use the magnification and do everything right, patency is even a problem. Reaching the end of the mesobuccal 2 canal is a problem because of the fact that orifices shift. There is a distance, even minor, between an uncleaned orifice to a cleaned orifice. So a lot of times we see this shift. Okay, a lot of times we see this shift even with the case that I had of the upper 7, and our younger generations always stab the manual file, it comes out bended, and say, doctor, it's calcified. Well, actually no, there is a mesial abrupt curve in the coronal 1 to 3 millimeter of almost all mesobuccal 2 canals. So orifice openers will let you pre-flare your canal, allowing the insertion of the manual files easily. As you can see in this video, I found the MB2, thank God, a dot of yellow. With my endodontic explorer, I'm removing away some debris. Notice here I'm gonna show you the ultrasonic troughing, just to remove any extra calcifications that I don't need. That's what we do. We insert the manual file, it's bended, it comes out with the coronal ledge, with the mesial abrupt curve. But if you choose to go with the orifice opener, you're with short strokes on the outer wall, you're actually making a lot of space and you have this engagement that you need. I also love a file that will come right now, the 8 teeth eFlex Gold. Yes, this one. It's tip 15 and taper 4. It will engage so smoothly after the orifice opener and make room for your rest of the steps. I'm here using a pecking motion because I don't want to risk overextending. I always look at the rotary file after I work because debris are a good sign of cleaning, and I went from this to this. I would like to also thank Perfect Dent to Seymour Microscope for this amazing pictures. Something happened to this case, the upper 7. I was so excited, and then bam, it turned into one canal. So I thought it was a type 2. It's actually a type 1, and it merged coronally. So just to stress on the importance of pre-flaring, it improves tactile senses, enhances cleaning, removes dentin mud, and make it a rule, according to studies, that when you meet resistance, consider the flare that's above this resistance, okay? I want to go more about the cleaning and shaping, but I'm overextending my time. But the best technique, in my opinion, along with the crown down, is something called the zone technique. And for narrow curved canals like the MB2, the zone technique is actually based on two objectives: that the canal diameter be large enough coronally to the curvature to allow you to clean the curvature, and also that the file diameter is not too large to rotate safely in a curvature. So what type of files? I always use these type of files: the eFlex Gold from 8 Teeth, the MG3 Blue from Perfect. We have the MPro Gold at EgyptAir Hospital. The Soko files, actually, I do love them. Their taper are very confined and amazing. And lately, the eFlex Edge, which is a flat design, it's causing a trend, and you should give it a try. The fifth step is actually obturating. You have two options: lateral or vertical. We're gonna demonstrate the warm vertical compaction. This is on the upper 6 that didn't have the MB2. So here I'm just cleaning with the eFlex Edge files. This is the flat design files from 8 Teeth. Flushing with irrigation. Oh my God. Here I'm activating the irrigant with the E3 ultrasonic tip. Notice how much debris are coming out even though I flared and cleaned with the last file. Don't ever underestimate the power of activating your irrigant. Bioceramic sealer insertion. Inserting with the Ktabrika heat condenser. Heated plugger, sorry. Warm vertical takes no time. It's really amazing. Warm vertical Gataperka and plugging. And this is the post-operative sealer puff, out of this world. Looks amazing. The MB2 that coalesced, do you remember? Well, I was compensated with inserting into the distal buccal and the sealer coming out of the palatal, which makes it a type 2, but in another direction. So not a lost cause after all. In with the gataperca, heated condenser. Takes no time. Lateral condensation is always letting you putting auxiliaries. This takes no time. Plugging, master cones, and the obturation. Notice how perfect the straight line axis. This was all done because of the straight line axis, really. And after all that you heard, will you find the MB2? If you find it, I will find you and I will thank you. Thank you.
Well, thank you, Dr. Indy. You made it look so easy. Thank you so much. Well, I guess it's time for a smile makeover. Now we have with us assistant lecturer at Future University in Egypt, Dr. Passant Saliman. Dr. Passant, the mic is all yours.
Good evening. I want to first say thank you for having me today. I'm truly honored. And I want to give it out to Dr. Inji. What an amazing lecture, and very informative. Thank you. Okay. So today we're going to discuss minimally invasive aesthetic options. Let's get out of the scope of endo a little bit and get into the aesthetic zone and discuss aesthetics for a while. The lecture's outline today is going to discuss how important it is to preserve enamel, minimal aesthetic treatments, and some case reviews from simple to complex. So, let's start by saying why it's crucial to preserve enamel. It affects tooth longevity, it affects bonding, and most importantly, strength. Enamel, we want to think of enamel as a precious, precious diamond. Enamel is the strongest tissue in the body. It's the best substrate to bond to. And any restoration bonded to enamel will increase its longevity. Imagine bonding to this surface, the picture on the left, and imagine bonding to the picture on the right here. Can you imagine the hassle of having to bond to wet, dentin, soft dentin that flexes, that doesn't give you a proper bond? What does the literature tell us about bonding to enamel? Well, mostly all reviews and all systematic reviews state that bonding to enamel increases the tooth longevity, increases the restoration lifetime. It gives you better shear bond strength, better bond strength to the final restoration. And most importantly, it increases the time of the tooth, the longevity of the tooth, the lifetime of the tooth itself. So after we've seen the importance of enamel, let's review some aesthetic treatments that we meet in our clinic on a daily basis. Starting with the bleach and bond concepts. Nowadays, when we see a patient complaining of his smile and coming in for a treatment for his aesthetic smile, the first thing that comes to mind is to do veneers. Actually, I'm an aesthetic dentist, I'm a cosmetic dentist, and I will tell you, stay away from veneers as much as you can. Not because they're bad or anything, but because precious enamel is not simple to reduce or just to prepare or remove from the tooth structure because we need it. We want to stay and think outside the box. We want to stay and think in a conservative manner. We have the bleach and bond concept. So I have this patient of mine, she came to the clinic. She's complaining of her dark teeth and the fractured teeth. She came in for veneers. Actually, when I looked at the case, I said she has perfect enamel. Her teeth sizes are mostly very nice and she doesn't need like an aesthetic makeover. She only needs some touches to her smile. So what I went for is the bleach and bond concept. We do bleaching first to the case and then we bond composite. So this is the case after it has been bleached. And this was the steps of the composite fabrication. And this was the post-operative smile for the case. We did very simple treatments without causing any harm to the enamel, But what we have is a very aesthetic and nice smile to the patient without tooth structure loss. And this is the perfect scenario that we're looking for. This is the before and after. Okay, let's review another scenario that we meet in our clinics on a daily basis, the diastema. And the diastema could range from a simple diastema, like a 1 millimeter diastema, or to mostly a larger size diastema, like this diastema on the bottom photo. It's like a 3 or 4 millimeters diastema. The same concept applies. When this patient comes to the clinic, the first thing that we'll think of is to do veneers and prepare those teeth and prepare this precious enamel and insert the veneers. But actually, let's think about the bleach and bond concept. So we'll start first with the first simple case. Here I chose to do composite because the diastema is really small. We also have to understand the nature of composite. Composite, when applied in small segments and supported by enamel, it gives you the best outcome of the material. So when we bond only 1 millimeter of composite, we're going to get the best out of this composite in case of strength and aesthetics. So this is why I went here for composite. This was the isolation, and this was the case post-operative. We just closed the diastema and gave the patient what she needs without having to reduce the enamel or affect her beautiful smile. Moving along to a more complex case, the big diastema. So this was also my case. She came to the clinic complaining of the old composite she had between her diastema. Looking closer, you can see the composite is really poorly bonded. This was after we removed the old composite. Here, I had a choice to go with composite again or to do Emax. But imagine with me, if we do the conventional preparation for an Emax veneer, what we're going to do, we're actually going to shave off a lot of this tooth and precious tooth structure from the tooth. But instead, what I went for is, I want you to see the enamel and how intact it is. This is the perfect substrate for bonding. What I did was here, I did mini veneers, partial Emax veneers. In this case, the porcelain was feldspathic porcelain. So these are actually feldspathic porcelain, but partial veneers. Instead of veneering the whole surface, we only veneer the part with the defect. So this was the try-in of the veneers, and this was the veneers after cementation and follow-up. This is the side view. As you can see, actually partial veneers, and we're going to discuss it briefly in our presentation. Partial veneers blend really well with the tooth, so we don't have to cover all the surface like we used to with the conventional veneers. This was the before and after. A very satisfactory result. I'm happy, the patient's happy, and most importantly, we saved the tooth structure. So let's talk a bit about partial veneers. Now, with the advancement of the materials and the advancement of the technology, we can actually prepare very little amounts of the tooth structure and replace them with only partial veneers, veneers that only hide the defect that we have in the tooth. We don't have to completely shave off the tooth. We don't have to prepare the whole teeth, the 8 anterior teeth. But here also we're talking about really minimally invasive treatments for minor aesthetic problems. So this is one of my cases. I want you to see, this patient came to me, he's young age, he's like late 20s, so he's very young. He's complaining about the spaces that he has and the irregularities in the sizes of his teeth. What I chose here to do was partial veneers without any preparation to the tooth surfaces. This is a video showing you how thin the veneers are. Actually, the veneer can last or can be thin as much as 0.1 millimeter, which are like paper thin. Can you see? Actually, the veneers doesn't cover the whole surface of the tooth. It only covers a partial part, and this is what we need. We only want to hide the part with the defect. The veneers, you can see, it's a partial veneer. It only covers the part of the tooth with the problem. And I must say, this case was zero preparation. We didn't touch the enamel. So I have a very satisfactory result from the patient. As for me, I was over the moon. I was really happy because we saved the precious enamel. So moving along now to a more complex variety of cases when patients want aesthetic treatments, not just limited to one teeth or two, but to the whole smile makeover. A lot of people ask a lot of questions when it comes to mind. What material to use? Do I use composite or do I use Emax? Actually, with the advancement of composites nowadays, composites can give you a very aesthetic result and can last up to 10 years in function. This is according to evidence. This is not what I'm saying from my clinical experience. No, this is the papers and the systematic reviews. They say composite can last from 7 to 10 years functioning and retaining its polishability and bonding in sound tooth structure. But given that we bond to enamel, 100% bonding to enamel gives you 10 years lifetime of composite. If you can see, if you can pick which tooth, which actually treatment is Emax and which treatment is composite, as you can see, actually this case, this is the Emax case, and this is the composite veneers case. So both cases give you similar outcomes. Both cases give you a very nice aesthetic look. And both cases were actually minimally invasive. But what I mean is they both give you the same aesthetic result. It all comes down to durability. As you know, Emax is very durable. Ceramics are very durable. They last up to 15 to 20 years. On the other hand, composites, they last around 7 to 10 years in function. So, how to choose the best material for the patient? By proper diagnosis and proper case selection. We have to understand if the case is additive, if the case really needs veneers, or we just need minor aesthetic interventions to give you the best aesthetic results. After that, we move along with the patient, and this protocol is applied to any aesthetic case that comes to our clinics. We first do proper diagnosis, and then we do the full photography protocol, and then we do DSD, digital smile design. We do a case analysis and treatment planning, and then we come out with a mock-up. A mock-up is your eyes, is what the patient sees beforehand of the treatment, before you start the treatment, and what you apply to the patient, and you understand what you're going to do in case of preparation, in case of material selection and cementation. And then you try the mock-up, and then the treatment starts from there. The patient has to see the mock-up, and you have to do a mock-up before intervening in any aesthetic makeover to get the best result. So let's move ahead to a more complex case. This case, she actually, my friend, she came to me actually in 2018. So this case was like 6 years old. She came 6 years ago. She said, I don't like how my teeth show. They have spaces, they are yellow, we have mild crowding and mild crookedness. As you can see, the side view, you can show the spaces, the overlap of some teeth apart from the others. So what I did was, in 2018, the patient here was like in her mid-20s, I suggested to have composite veneers done. And needless to say, we did the composite veneers without any tooth reduction, without any removal of the enamel. First thing we did was laser gum contouring, guided by the mock-up. And then I started to do bleach and bond concept. I bleached the teeth first, I did whitening to the teeth first, and then I started with the composite fabrication. So this was the final result that we have, a very satisfactory result given that we didn't remove any of the enamel that she has. Her tooth structure is completely intact. So this was the result, the final result that we had for the case. Fast forward 2 years, the patient actually, given that she's my friend, I saw her a couple of times, I see her frequently, so I get to follow up her closely and monitor the case. 2 years follow-up. As you can see, the composites is intact. She's very happy. I'm very happy with the composites. And we have a perfect treatment plan. Move ahead after 5 years. 5 years fast forward, those are the composite veneers. Actually, for me, it's a very satisfactory treatment because the patient has still her intact enamel, intact smile. She was just upset about her teeth being a little bit dull. This is what happens with composite on the long run. They lose their polishability and they become a little bit dull. But with the advancement of the materials nowadays, we can use composites that have zirconia and silica inside of them, so they have better retaining of the polishability, because this case was done like 6 to 7 years ago. Now we have better composites, so I have to say that. So the current treatment plan for me was, I suggested that we remove the old composites and go ahead with Emax. But also, what I suggested that we do non-prep Emax veneers without any reduction. And the question that comes to mind always from people is, if we do veneers that are done without any reduction, can we remove them later on after they serve the lifetime that they have? Can we remove them and have the enamel, the intact enamel, the sound enamel back? Yes, we can. As long as the tooth structure has not been touched, the enamel is intact, the dentine is not showing, we can remove any type of veneers very conservatively, of course, and have the intact tooth structure again, back again in function as it used to be. So what I did was, and this is the protocol I do for all my cases, the case when it comes to the clinic, after I do the proper diagnosis and talk to the patient, I take a scan. I take a scan with a digital scanner, and then we do a mock-up. Here on the mock-up, we started to design veneers for her 8 teeth. We started to do the design, and I started to study the case through the mock-up. I said, her teeth are really small. She has full-sized lips, so it's an additive case, a case that requires addition, meaning when I add to the tooth, it would give me a better outcome and a better result and a better aesthetic appearance. So we tried out the mock-up in her mouth, and she was excited, really excited, and she said, yes, this is the type of look that I want for my smile. So what I did was, I tried out the mock-up, and then I challenged myself. I was sure that this case was going to be non-prep, meaning I would not touch the enamel because I already measured the amount of the mock-up on the software, and I know exactly the amount of tooth structure that's left underneath the mock-up. So we did preparation over the mock-up, and those were her intact teeth. As you can see, this was after composite removal. 6 years later, her teeth is sound, her enamel is sound. We didn't lose any tooth structure, so we have the perfect treatment for her case. So what we did was, I took another scan after the composite removal, and we designed feldspathic porcelain veneers that are without any preparation. They are ultra thin, and they give us a very nice aesthetic appearance. This photo shows us the side that has the veneers and the side that has the mock-up. So those are the try-in of the veneers. I actually want you to see how thin the veneers are. They are paper thin. They are very thin. They are completely aesthetic. They are very translucent. So we have the perfect veneers without having to compromise her teeth and prepare her tooth structure. So a very important aspect with the non-prep veneers is to have highly polished margins, meaning the margins after cementation have to blend with the tooth structure and be properly finished and polished by our contra and ceramic polishers. This is what we mean by partial veneers, that we have some surfaces of the tooth actually uncovered, but the outcome that we have is no preparation, and we have actually nice looking veneers, is what gives us the best outcome in the end. So this is the patient, the before and the after. This is fast forward 6 years ago. So all of this, we are saving the enamel. We have 8 years of veneers, composite and then Emax, without compromising the enamel. So this was the case before in 2018, and this is the case now in 2024. So to sum things up, I want to stress on the importance of saving enamel. Enamel is your key way to an aesthetic outcome that's long-lasting, that's actually bonded in a very, very proper way, and that will give you the best aesthetic result. And also, I want you to think outside the box. Not all the cases require preparation. Not all the cases have to be prepared with removing the enamel. Minimal treatments are actually enough to do the job. Thank you for having me. I was really honored. This is my Instagram page. I always put educational content on my page, so I'd be very, very happy if you give me a follow. This is the QR code to my account. Because stay tuned, and we always post cases and educational content on our page. Thank you so much for having me. It's been a pleasure.
Thank you so much, Dr. Basant. Your patients are definitely smiling with more confidence now. To wrap it all up, we'd like to thank our honorable speakers and all the presents for being here with us today, sharing with us the second International EgyptAir Medical Congress under the auspices of Dr. Ayman Salah, Chairman of the Board of Directors at EgyptAir Hospital. And of course, many thanks to our fellow colleagues who put this all together and made it happen. Thank you, and I hope you enjoy the rest of your day.